Welcome, everybody. This is our panel discussion on psychedelic-assisted therapy for PTSD. And this is the second and final webinar on this topic and is following the excellent primer and overview session led by Dr. Leslie Morland 3 weeks ago. If you didn't have the chance to attend Dr. Morland's talk, it's now available both on the ISTSS website and on YouTube. And Dr. Morland is also joining us once again for today's panel. And in a few minutes, we'll reiterate a few of the takeaways from her talk to help set up a framework for our discussion today. So in the interest of time, I'll start with some very brief introductions. I'm Dr. Anthony Reffi. I'm a licensed clinical psychologist and assistant scientist at Henry Ford Health System in Detroit, Michigan, United States, where I also direct the research program for our outpatient trauma recovery center. I will be moderating this panel today alongside my co-moderator, Dr. Sonya Norman, who I will ask to introduce herself.
Hi, I'm Sonya Norman. I'm very happy to be here today and to learn from our panelists. I'm a professor of psychiatry at the University of California, San Diego, and I'm on the board of ISTSS and lead the Public Information and Education Committee, which brings you excellent speaking things like this. Thanks.
Thanks, Sonya. And now to our wonderful panelists, Dr. Leslie Morland, Dr. Barbara Rothbaum, and Dr. Ann Wagner. If you would each please introduce yourselves, including 1 to 2 minutes on the work you're doing in the psychedelic therapy space. And we'll start with Leslie and then move along to Barbara and Ann.
Hi, yes, thank you. So I'm a clinical psychologist at the University of California, San Diego Department of Psychiatry, a professor here, and I've been working in PTSD clinical trials for a couple of decades, and more recently have been looking at how MDMA in particular can be used to accelerate and or enhance some of our established psychotherapies for PTSD, specifically with couples and or individual PTSD treatments, and have also trials with oxytocin and other ways to augment. So coming today as a PTSD clinical trialist would be probably the best way to describe it.
And I'm Barbara Rothbaum. I'm a clinical psychologist as well and a professor in psychiatry at Emory University School of Medicine. I direct the Emory Healthcare Veterans Program and have been doing clinical research in PTSD almost as long as PTSD has been an official diagnosis, since about 1986. Been testing a lot of different treatments. We've been doing translational research with MDMA, looking at its effect on the extinction of fear for about a decade now. And more recently, we are combining MDMA with prolonged exposure in a 2-week masked format. And we've just seen the 12th patient. So we're piloting how that works together. And I'm excited to be here. Thank you for including me.
Thanks, Barbara. Hi, everyone. I'm Ann Wagner, also a clinical psychologist. I'm in Toronto, Canada, and I work out of Remedy and Remedy Institute, which are a clinic and a charity, and we run all of our research out of the charity. I'm also an adjunct professor at Toronto Metropolitan University in the Department of Psychology. So I've been involved in MDMA research since about 2013, so going on 12 years now. And I've been an investigator, a co-investigator first on one trial of a pilot of cognitive behavioral conjoint therapy, which is a couples intervention for PTSD plus MDMA. And then I've been the lead investigator on a project of cognitive processing therapy plus MDMA that's just concluded. And now a large randomized trial of CBCT again with MDMA. And so I've also been very, very fortunate to actually get to work with both Leslie and Barbara on their MDMA studies as well. So I have a nice view or bird's eye view into all these different projects. So looking forward to this.
Fantastic. Well, thank you all so much. We're very, very excited to have you. And for our attendees, the purpose of today's panel is to just have a sort of broad range discussion. We do have some questions that were submitted after Dr. Morland's webinar a few weeks ago. So we will refer to those throughout. But at the same time, we do hope that Dr. Norman and I will be able to sort of facilitate ongoing organic discussion throughout today's panel. So before we do that, I'd like to ask Dr. Morland to just provide a sort of broad strokes overview of her talk from a few weeks ago for folks who weren't able to attend to help orient our discussion for today.
Great, thank you. Yeah, and the goal, I think, of the two-part webinar was a couple of weeks ago, I did a very broad, rather condensed overview, and really encourage folks, if they want that larger context, the history of psychedelics, why now in particular we're seeing this resurgence, why in the area of PTSD do we kind of maybe all agree we need more treatments, there may be ways to move our treatments forward. And so really this idea of how psychedelics and PTSD, perhaps it's a unique moment in time where this research is particularly important. I also do make some distinctions between like psilocybin and MDMA. I think we'll be focusing mainly on MDMA today, which has been perhaps the most focused on when it comes to PTSD, although psilocybin is getting some interesting work underway with PTSD, but has more historically been more focused on depression. I think, we really want to talk a lot about this excitement and the promise of psychedelics, and also at the same time, the need for research and the need for rigorous, equipoised research to really be able to move the needle in terms of treatments that can help veterans safely, help patients safely. And so what I wanted to set the framework for today was this idea of what we call psychedelic-assisted therapy. And not all psychedelics are done in the context of psychedelic-assisted therapy, but really this idea of how do we use the psychedelic with a psychotherapy synergistically to treat PTSD. And to date, MAPS is probably the one that's done the most when it comes to PTSD with MDMA. They have their model of psychedelic-assisted therapy. But as was just discussed, Barbara and Anne, and to some extent myself, have been really looking at additional models that I think have a lot of potential promise in terms of being able to be taken to scale. And so hoping that we can talk a little bit about those, what's been learned, but also then at back end talk also about clinical considerations, ethical considerations, for all of us in this space. I think there is a lot of excitement and there's a lot of things we want to be thinking about when we try to take this to scale. So hopefully setting the frame for this talk to drill down a little bit more, since the last talk was a kind of a scoping overview.
Yeah, fantastic. Thank you so much for that. So yeah, I'm thinking now actually, after hearing your overview of what you discussed a few weeks ago, if maybe a good starting place for us is talking about sort of where are we right now. So maybe we don't want to sort of rehash the history, since that was a large focus of your webinar a few weeks ago, but just kind of bringing us up to where are things at right now, and maybe that would be a good opportunity for each of you to talk about how you're contributing to the current research going on in this space.
So yeah, I can actually just do a quick summary, I think, and then I will turn it to Barbara and Anne to chime in. I think in terms of MDMA for PTSD or psychedelics for PTSD, which I think right now the forefront has really been MDMA. There's been 2 phase 3 studies that have been completed, and there was a recent review by FDA to determine if MDMA could be kind of recategorized as no longer a Schedule I drug and have an indication for the treatment of PTSD. And there was a lot of enthusiasm and anticipation, and ultimately it was not FDA approved. So again, there's been a handful of phase 2 studies, 2 phase 3 studies. And just to summarize the FDA and why that decision was made to my best of my ability, and I'll certainly have other folks chime in, and kind of then like, what does this mean moving forward, is that some of the biggest concerns were around not having an active comparator, which can leave some challenges for psychedelics. Well, one, it's hard to get a good active comparator with psychedelics because it's a very subjectively profound experience. The absence of an active comparator can leave open a lot of potential for placebo effect. And so that was a concern. I think there was also concerns around the lack of maybe including a structured evidence-based psychotherapy with the psychedelic. So the MAPS model includes a more inner-directed approach that is theoretically a little bit different than what maybe we're currently doing with our treatments for PTSD. I think those are two of the big ones that were a concern. And I think really the end result, though, is there's a lot of promise, and in some ways the FDA has kind of given us a little bit of a roadmap of like what we need to be doing to really do this next phase of research, and being able to be thoughtful about how can we have models that consider the FDA's concerns. I think the last thing I'll say is that scalability is a big one, and being able to approve something that has some potential to be also a little bit efficient, so we can actually have an impact on the field. And that's, I think, a decision point right now with like, if we take something that's scalable, do we lose the essence of what the psychedelic offers? I think that's the space we're in right now in terms of how do we move forward. But I'll turn it over to Barbara and Anne to make sure. I'm sure I missed many other aspects, but that's kind of a summary.
Sure, I can chime in here. So I think as someone who's been involved in the field for a while and has seen this evolve from the phase 2 studies to the phase 3 studies, and having been doing these other models kind of in tandem and alongside these models also being tested, what's interesting is the amount of data we now have on this inner-directed approach is really sufficient for it to be an evidence-based therapy, which is interesting. And that's, I think, a piece of conversation that perhaps didn't get to its fruition before the FDA review, but that there was a very strong fidelity rating that happened throughout that. And I think that that's part of the conversation now that will be brought forward, and from my understanding, in future conversations with the FDA, and also in consideration if we're going to be using a different psychotherapeutic model alongside and kind of in tandem with the MDMA. And I think it's been interesting, particularly as someone who has, having done the CBCT trial pretty early, quote unquote, early on in this MDMA research resurgence, and then the CPT trial, I often am asked these questions about, do you think that these are as a better combination with this? And I think that that's maybe not the right question to ask, but rather it has to do with it's a scientific question, but that's also a question about choice eventually, and who providers are, and what they're going to be want to do, but also what clients are going to eventually want to do as well. Because in the two pilots that we finished, the treatment itself is quite short. It's done within the course of maximum 2 months, which in and of itself is kind of this masked or intense dose. We can talk about masked in different ways, but it's a quick shot of therapy that's quite intense. And the inner-directed approach also is pretty quick and intense. It's a little bit longer than that, but I think that there's the possibility of having options and having different things be tested. But I know, for example, in my work, our MDMA sessions look very similar to the inner-directed approach, meaning that we're blending these models in prep and integration, which are how you get ready for and how you make sense of the MDMA session, is using these other psychotherapies as those scaffolds. But that's one way of doing it. And I think between all of our work here, we're covering many different models, which is really fascinating to me, because we're developing evidence that they can all work, which is great. Barbara, I'll hand it to you.
Thanks. Yeah. And I really first started really paying attention to MDMA when I saw, I think it was like a 4-year follow-up study, and patients had maintained their gains. I thought, okay, there's something here. And then in the 2 phase 3 studies, in the last one, I think 70% of people met remission. I mean, we don't see results like that in most of our other PTSD clinical trials, and certainly not the SSRIs, but even in the trauma-focused therapies. And the dropout rate was very low, lower than in most other trauma-focused therapies. So I definitely think there's something here. We've often taken a translational approach. For example, we did the decycloserine studies that started in animals, and then we did them in humans. And I've done combined SSRIs with prolonged exposure and CBT. So in general, for a long time, we've been looking at ways to try to augment therapy to make it better, to make it more useful to more people. And so MDMA in our translational studies, we saw that it facilitated the extinction of fear in a rodent model. We saw in a human model, healthy human, there were more extinction retention responders. And so what that means is their bodies remembered that they didn't need to be afraid anymore, with so obvious implications for PTSD treatment. And so it just seemed natural to combine it with prolonged exposure. In the Emory Healthcare Veterans Program, which we're celebrating our 10-year anniversary this year, yay! But we've been using a 2-week intensive outpatient program model, masked PE, and we have a better than a 90% completion rate. So I love the IOP model for treating PTSD because it feels like we've solved the problem or part of the problem of dropout and avoidance in therapy. So again, it made perfect sense to combine MDMA with this model that has great retention. Want to make sure people know we're not exploring this as a replacement. Like Anne said, we want options. We want options for people. There's some big differences. We're only including 1 dose of MDMA. And after we've got a lot of research on a lot of different models, I think it's going to be important to try to find predictors and figure out which treatment for who would really need the 3 doses, who does fine in 1 dose in a mass treatment. I mean, there's so many differences between our treatments. And so seeing what works and then figuring out what works for whom, I think are going to be some of the big questions.
So hearing you each talk about the different approaches being done within the field and being done by you all and talking about these treatments as options is making me wonder, is it that psychedelic-assisted therapy sort of on its own is another option to PE on its own, prolonged exposure on its own, cognitive processing therapy on its own, EMDR on its own? Or are we seeing sort of subsumed within psychedelic-assisted therapy all these other options, right? So whether you're pairing it with a PE or something else, or whether you're doing it masked, or whether you're doing it with these preparation and integration sessions, or are all these different approaches that are being done right now within psychedelic-assisted therapy still sort of an effort to find sort of the optimal way to do this? So I guess to simplify my question, is it that we are hoping to have all these options within psychedelic-assisted therapy in terms of doing it masked, doing it with another evidence-based treatment, or doing these longer sessions of dosing? Or are we trying to find sort of the optimal psychedelic-assisted therapeutic approach so that that is kind of a one-size-fits-all treatment package that's an alternative to the other EPPs for PTSD?
I can try first on this one. So I really think, Anthony, that we're not going to have one optimal solution here. I think we're going to have part of what we're doing is trying to find different models that would be appealing to different people, but also I really don't think, if we do a horse race between different models of what's going to be better, that we're going to find anything, which is we often are not finding anyway when we're doing psychotherapy horse races. So I think I often think about it more mechanistically, right? Like what's happening and also the common factors across all these different approaches. And that there's this idea of you might choose a different doorway, right? A different path to go in, right? You might be choosing a cognitive doorway, or you might be choosing a behavioral doorway, or you might be choosing a relational doorway, right? But you're leading to a very similar place. And I think that has never become more apparent to me than working on these trials, and especially having this bird's eye view across all the trials, which is a real gift that I get to see how the MDMA sessions are working, and really they're amplifying whatever is the person's experiencing, whatever they need to go into, and they're often being primed with the different languages of the different therapeutic modalities, but they're always getting to that place, which I think is wonderful. And I think that means that the use of a psychedelic can really be an amplifier of whatever the active ingredient is in the therapy that you're working with. So I really don't personally think there's going to be a one's better than the other. I think it's which doorway do you want to walk in? And now we're asking the question, can MDMA amplify that pathway? And we will continue to figure that out.
Yeah, and I agree completely. And I'm less interested in any horse races, especially at this point. I mean, at some point it will be interesting and to try to figure out again which treatment for whom, but we need options. And it feels so to a lot of people who've been doing the MDMA assisted therapy, it's anathema to them that we would do imaginal exposure to someone on MDMA. And then, but to me, it just feels so natural and it feels so synergistic. It feels like the MDMA, like with PTSD, it feels like the brain is locked with these memories and these experiences and reactions. And it feels like the MDMA opens the brain to then process and do what we need to do in imaginal exposure. It all feels like it's like, yeah, and I agree that we're headed the same place. For me, it all feels like processing the traumatic material, having a different relationship with the traumatic reminders and memories, and being able to have lead the life you want to lead right now.
And I would just also chime in that whether behavioral, cognitive, relational, I love that kind of framework. And, one of the challenges across this is, I think, getting a individual who's struggling with PTSD to kind of be able to do that deep processing from whatever theoretical lens you want to look at. And, avoidance and fear and all these things that can really become barriers to really benefiting from the therapy, and how does something like MDMA lift some of these barriers to really allow for that deeper level of work. And I think, again, you could look at it through different theoretical lenses, and we're all, I think we'll get to the same place, but it does seem to be a catalyst. And for many of us who've done a lot of PTSD work and have worked with providers, I do think there's a toll that it takes when you're working with a lot of veterans or patients with PTSD, and you're kind of trying to get them to the place where you feel like you want that heavy, deep work to happen, and you can't get there. And so I think this idea, how can MDMA facilitate what we're already doing wherever we may be doing it with our PTSD work? I do want to say one piece that I think is really important is, obviously all of us are always thinking about safety, and we're thinking about clinical efficacy and kind of what is the question of what I'm trying to accomplish. Am I trying to accomplish fear extinction? Am I trying to reconnect with my loved ones? One of the things I've spent a lot of my career thinking about is access. And I say that because I've come to this space and have spent about 2 decades thinking about how do we make sure that no matter where someone's located, no matter their kind of economic situation, that they have access to good treatment that works. And then I found myself doing this MDMA work. I'm like, this is not terribly accessible. So I think the question is, I think depending on the system of care you work in also, what are ways that we can be thoughtful about safety, clinical efficacy, and access to the folks that we think need this and could benefit from this most. And so there's different kinds of systems questions that I think also might drive some of the choices that one makes about the various treatment options that are available. And so each of us might be sitting in different kind of positions when we kind of come to the table and think about how could this work in the system of care that I might be working in.
I'll jump on that because we've got the 2-week program that in some ways it's hard. If I had to take off work, leave my family for 2 weeks and go somewhere else for treatment, that would be hard to do, and it would take me a while to do that. But if I was dealing with a chronic illness that I've been treating maybe every week for years and not getting where I need to be, it's worth it. And ours is the veteran program, although in our studies, we're also treating civilians with the MDMA and combined PE. It feels very efficient that people can take off 2 weeks and just eat, breathe, and sleep the therapy that they need to do, and then hopefully come out of the other end feeling better. I also think that we might be capitalizing on the plasticity induced by the MDMA, and it's theoretical, and you can't translate animal days to human days, but the estimate is that MDMA opens up this critical period, opens up this window for maybe about 2 weeks. And so we're thinking that by then giving them prolonged exposure every day afterwards for 2 weeks, that we might be capitalizing on that plasticity for the learning that occurs. I also just want to make a general point that we've all made, but I want to make it really clearly. No one is advocating just MDMA by itself. Everybody is advocating MDMA plus therapy or psychedelics plus therapy. And I just want to make that really clearly in terms of don't do this at home. Don't just think, okay, MDMA is helpful for PTSD. I'm going to go do ecstasy and expect to have therapeutic benefits.
And I would add that the talk that I did a couple of weeks ago makes that distinction between like even the psilocybin models, which is psychological support. Really, everything with MDMA is the synergy with the medicine and the therapy is, I think, one of the unique kind of aspects of MDMA. So I think that's a really important point to emphasize.
I agree with that. And also just emphasizing that MDMA is so malleable to set and setting in context, and setting it up as a therapeutic experience is so very different than if people were to take this in any other context. And the number of times I hear, wow, I don't know why they call this ecstasy, right, in the room, right? So is remarkable, right? Given that it's have a much different experience when you're there with therapists and working through deeply traumatic content. But also just speaking to the context piece. So I work in a different context, meaning it's a community clinic here that we're working out of. So our population is very different. We're in Canada, that's very different. There's our clientele here are a different group of people. And that we're doing it in this intensive, but very much outpatient model where it's, at the moment they're coming once a week for 7 weeks to do this treatment, or 8 weeks to do this treatment, but they're doing it in these big chunks. And so we do 2 MDMA sessions within our 2 different models with CBT and CBCT. And so therefore we have that same idea of kind of quote unquote capitalizing on the neuroplastic period afterwards. So they're doing intense deep therapy, but for us they're coming, for a 2.5 hour or 3 hour chunk once a week. So we've got the context of they're going back to their day-to-day lives, but they're in this intensive treatment and making space for it over that 7 to 8 week period, which we've also noticed is really helped. We have not had any dropout from treatment itself, which is remarkable when you think about PTSD treatment. They stick with it during the actual treatment itself.
To Anthony's point, I love the diversity of how you're studying MDMA in combination with therapies, both in terms of the type of therapy and then the frequency, the extent of it. I think we're just getting so much valuable data through you all and others who are doing this work. One of the things I found really exciting in talking with some of you recently is kind of the way you're thinking about some of the ethical questions that come up, because I think that they're very nuanced given that you're like in the trenches doing this work. So I think it would be really great for folks to hear about some of the things that you're seeing as kind of some of the ethical issues that we need to be thinking through and working out.
I can jump in on my piece is, I think, trying to balance clinically and as a researcher, excitement and optimism, as well as a healthy dose of skepticism. This is a strange space where there's been tremendous media hype, and folks who are wanting to be involved are often feeling like this is going to be like the magic bullet, and really trying to kind of ground individuals on like what we know and what we don't know. And while we do think there's a lot of excitement and promise, we do need to do more research. And I have found that has been tricky sometimes to make sure that we're not overselling or overpromising, but rather there is promise, but we do need to do more research. The other thing I wanted to just say, and again, having worked with maybe a more complex population, well, I think we all work with complex populations, we work with PTSD, but there is a taper that's required, and as many of us know, PTSD and depression go hand in hand, often PTSD and treatment-resistant depression, and there can be anxiety and panic and all kinds of other things that are presenting. And if you look at the trials, there's tremendous exclusion criteria. In fact, the majority of folks that either self-refer or get referred are not going to be eligible to move forward. And it does beg this question of who is this a good fit for? I think maybe some of the media attention has suggested that anyone who has PTSD could benefit from this, and that perhaps could be the case. But if someone's also struggling with depression and you take them off their medication and their depression comes back like a bulldozer in their life. And so I think these clinical and ethical considerations are ones that I think we want to be aware of. And something that Barbara said, which I think is a really important piece, is that because we are looking at psychedelic-assisted therapy, which is really the therapeutic use of psychedelics for a specific, diagnostic presentation, so to speak. There's a whole kind of other line of wellness and growth, and it's a little bit of a different in recreation. And what you don't want folks to do, I worry that folks are going to think that this is something that's going to work, and they're going to go do it in their bedroom by themselves. And that is not what we want. And so I do think, as a field, being thoughtful of like these kind of considerations that are both clinical and ethical, and how we present this with both research and whatever else we may be doing with these medicines.
Yeah, I think I echo a lot of what you're saying, Leslie. And I think also, for thinking from really a clinical angle, working with this, that MDMA creates, or doesn't create, it helps enhance feelings of empathy, allows you to access, I should say. It doesn't enhance it. It's not creating something that's not there. It's allowing you to feel empathy if perhaps you have not been able to feel it. It allows you to feel your emotions in a way that perhaps you felt disconnected from. And so as the therapists working with that, we have to be very aware of that, and we have to be very mindful of the connection that's forming, and that it's like any good psychotherapy practice, you need to be very aware of that and very conscious of that experience, but that it's, you're spending a full day with people in these MDMA sessions, and they're actually able to feel their emotions. They're able to feel empathy. And so you need to be aware of that, and also really checking yourself as a therapist of what's my stuff and what's coming up. And I think it's, yeah, again, like we always have to do that as therapists, but I think it's even more important in these moments. And that's an incredibly important and also nuanced thing that you need to have, like constant collaboration and conversation with other colleagues and peer consultation and review all the time around that. And I find it's one of the most gratifying therapeutic experiences that I have, and also one of the hardest. And so both things go hand in hand, and everything that you might experience in a therapy room is amplified. So you need to be thoughtful about that.
Yeah, and riffing off of our peer supervision, Anne has, I feel like, seen me and all our therapists in our underwear, helping us watching these tapes. And I've learned something from every single patient, every single session. And people talk about coming at it with beginner's mind, and it's true and it's accurate. Something that's been said a lot when we talk about ethical considerations is that patients are patients. And so we have an ethical responsibility to think about what they need, not our needs. And patients on MDMA are more vulnerable even than folks not on MDMA. And so I think that we need to take that very seriously. When some of our therapists went through the MAPS training, and they're like, Barbara, are we going to touch our patients? Because I've grown up, and a lot of us in the cognitive behavior therapy, trauma-focused world grew up, you don't touch PTSD patients. We have a yoga program and it's actually my yoga teacher, and I love it when they adjust me, but we've said, please don't touch our PTSD patients. You know, we're very careful about that. But especially with MDMA, a lot of times patients request touch, and it can be one way of offering support. So making sure that we do that in a very careful manner, that's always patient-centered, it's always consensual, it's always non-sexual, is another ethical consideration that we pay attention to.
Yeah, so I guess to try and distill as best as possible these safety and ethical concerns into a clinical pearl for folks. You know, what are we doing? How are we reconciling these tightly controlled trials with the not uncommon world patient who's on a cocktail of prescription medication, who has comorbid substance use disorder, has a complex trauma history? You know, what do we tell those clinicians?
I mean, I guess, are you asking whether if they should be referred to the study, or if this is a good fit for that population? I mean, I think it's a complicated question, and I think that I feel like we have some pretty clear exclusion criteria, but I do suspect that I think one of the areas of research is what criteria can we loosen in order to maintain the safety and the efficacy, but also to allow for folks who might have comorbid conditions, some of which are secondary to the PTSD, some of them may not be. But I think, the goal would be how can we really push forward with as much availability, keeping safety and efficacy in mind. So, for example, some MDMA, you have to taper off an SSRI. There's concerns about serotonin syndrome. There's also concerns, but there's also concerns about blunting the medicine effect. So it's not just as safety; it's also about being able to maximally benefit from medicine. And I think these are all areas, I think, of research when we start to translate what do we know and who is this going to be a good fit for, with the idea that the hope is that most folks with time will be able to have clear ideas of who this is a good fit for. I think we're definitely learning that now. I think when you take a Schedule I drug in trials, the error is on the side of safety and rigor with inclusion and exclusion. If we move to the point of rolling this out with approvals, I think some of that will get loosened up. Which criteria is hard to say at this stage, but I think that would be the hope.
I think adding on to that some of our psychological or psychiatric exclusions are we're going to be gathering more information, and particularly around kind of the container, we call it the container that the person's therapeutically in, and what supports are there, right, around that. So, for example, what may have been an exclusion for previous trials, for example, around suicidality, may actually be the target of treatment in very soon to be upcoming trials. So I think we're going to learn a lot more around that with very careful safeguards, considering the care and support of our participants, and then hopefully therefore more people in the future.
Great, thank you. Yeah, I was reviewing the questions from the part 1 webinar and trying to keep up with the questions coming in now. And this seems to be one of the most frequently asked questions of like, well, what about for this patient? What about for that population? So it sounds like we are, we don't know yet, essentially. And this work is still very much ongoing. We're still balancing the methodological rigor needed to understand these medications with figuring out, where we're going next. But these populations are by no means off the table. This is still very much an ongoing research question.
Yeah, go ahead.
I was just gonna say, I also think there's always a cost-benefit analysis, and I think that really, weighing, the benefits of this type of treatment for a patient and the costs of, whether it be, a taper, whatever it may be. I think that is a clinical careful balance, and I think will be more and more thought through as we get more information. Go ahead, Barbara.
I forgot what I was going to say.
One question that's kind of recurring in the chat, which is very speculative, but I think it'd be interesting to hear your thoughts, is about mechanisms. And so someone is asking, is it that people are more suggestive? Is there some other biological mechanism? Barbara, you mentioned neuroplasticity. It also makes me wonder, do you think the way that MDMA is facilitating, say, PE is the same or different than how it's facilitating CBCT or CPT? Very speculative, but I think it would be really great to hear your thoughts.
Yeah, I think we are so far from answering these questions. Like thinking about the number of trials we've run so far and the number of people we've seen, it's like this much comparatively to, other other trials that have been in the world around psychotherapies. So I think that there are multiple mechanisms at play, and we can speculate about all of them, including fear extinction, including cognitive processing around things, including attachment, including being able to be with your emotions in a different way. Like there's all kinds of ways, and non-avoidance, all these pieces, but we really just don't have the data yet to actually parse that out. But certainly we're working therapeutically with all of these different mechanisms. And from what I've seen across all these trials, and including the interdirected approach, it honestly, like how it changes looks very similar across all of them. And so I don't think that there is one mechanism that's like, this is the winning one. I think it's many of them that are interacting together.
Yeah, and I think, so what I was going to say before is I think as long as we're treating PTSD, I mean, so we're talking about other comorbidities, but for me in these trials, my eye on the ball is that PTSD is primary and that's what we're treating. When we're talking about the mechanisms, even when I talk about fear extinction, it's reductionistic. I know it's reductionistic. I almost hate it when I talk about it or when other people talk about it, because people get so focused on it and think that's all that it is, and it's not. And it's when we're doing prolonged exposure, it's a very intimate experience that the therapist has with the patient, and we're riding shotgun with them in the worst moment of their lives, and we're there with them in recounting the memory. It feels like one of the common denominators of a lot, well, so it feels to me that one of the common denominators of PTSD is avoidance, that they have avoided the memory or processing it or talking about it or dealing with it in a way that it hadn't been processed, and it's interfering in their lives, and that's the haunting nature of it. And so it feels like one of the principles that MDMA might be doing in all of these is helping people approach some of these memories, emotions, feelings, and that they've been blocking, and that allows whatever therapeutic mechanism is going on, it kind of gets them to the plate for that.
And I would agree that I also think in my mind, I try to separate out the psychological or phenomenological experience that you're seeing, observing, being part of with a client. And then of course, our desire to know what's happening in the brain and what's happening with the neurochemistry and so on and so forth. And really being able to, it would be lovely to have some of the objective data of what these things are happening to corroborate this kind of very powerful phenomenological and or psychological experience in the room. And I think to Anne's point, we're not there yet. I think there's definitely some reason to believe that, there's neuroplasticity, there's reduced fear response, there's like changes in amygdala activity. I would agree with Barbara that the idea of sitting with a patient and their fear response is down, and so you're just able to move forward and approach, which is well, you could spend so much time just getting that to happen. But if you're starting therapy with that already in place, it can just feel powerful to observe the growth. The other thing I would mention is I think MDMA is the only psychedelic that has this pro-social piece to it. No other psychedelic has that. And it's this idea of not only are they able to look at content, but they do it through the lens of compassion. They do, compassion for yourself, compassion for others. which is a different perspective if someone's been hung up on feeling grief and shame and guilt or anger. And I think the other thing that you observe is this ability to zoom out and really get unstuck from the way you've been thinking for so long. And so I think it can feel very powerful in the room. And I have colleagues who say, I'm never going back to regular therapy. Like this just makes it feel so much more kind of invigorating for the therapist. And the last thing I'll say, which I think is a point that resonates with me, and I use this a lot with clients, where it's with MDMA, you're not going to feel ecstasy. It's not about feeling good. It's not about feeling better. It's about getting better at feeling. You're actually able to feel more. And so, we try to not say this isn't about feeling ecstasy or pleasure, or it's about feeling when you've been numbing out for so long. And so I think it really helps translate for folks what we're trying to accomplish.
I love that, Leslie.
I think that's Michael Mithoever's statement. And
I love it. I want to steal it. I want to borrow
yeah,
it.
but it does translate for folks in the room, because I do feel like they come in, like to Anne's point, like, I'm going to be on X, I'm going to feel good. It's like, no, you're going to feel, and you haven't felt in your body or in your heart. Like a lot of these things they've been kind of blocking. So it's a lot of translation that happens also in the room. But
Yeah, it sounded like these medications are really kind of stripping away a lot of the, sort of, if you will, defense mechanisms that are sort of preventing people from approaching the memory, accessing their emotions around the memory. And it makes me think if maybe in the last few minutes we have here, if we might start to wrap up with maybe some clinical examples and anecdotes. I was reviewing the talk a few weeks ago by Leslie, and he had some really, really powerful quotes in there, both from patients and providers. And, um, it got me thinking about some of the very moving experiences I've had with patients after doing something like prolonged exposure. And something that's always been unique to me about PTSD treatment is that I've not yet found another population who, by the end of successful treatment, is able to report such a sort of transformation as compared to when they began. But that being said, reading some of these quotes and excerpts from the psychedelic assisted therapy trials, it sounded like there is something very different still qualitatively about these patients' experiences. And I guess I'm just wanting to better understand what that looks like in the room. And I kind of have a double-barreled question, just in the interest of time. I want to make sure we have a chance to address this. How are patients reacting to these medications in terms of the potential of taking them? Not how are they sort of reacting after they experience the dose, but I don't work with veterans anymore, but when I did, anecdotally, almost all of them were very apprehensive about starting a new medication. So I guess I'm curious to hear how this is different, both for veterans and the civilian population.
Glad to go first. I think, we have a biased sample in terms of these are people who are seeking out enrollment in this study. So obviously they're open to the idea. But I've noticed even in the change between several years ago when this was new, but the hype was huge. People were clamoring to get into the study. And now people are interested, but they're also feeling really thoughtful about it. And also I'm working on a couple study right now. So there's two people trying to figure out if it's going to work for their lives and what they need. And so there's not trepidation. Well, there's lots of anxiety around trying something new, but there's a desire to try something different that's there. But certainly I'm working with a community population who are looking for a different treatment option. And then I'll add into the case piece. And so the case that comes to mind right now is a couple that we worked with in the first pilot. And this is a couple that had been in a very long standing relationship over 30 plus years, and PTSD had really been present throughout that time, and it caused a lot of grief. It had caused a lot of harm in the relationship, and there was a lot of fear around connecting around various things, but also of trying to keep things okay in the relationship. So there was a lot of accommodation. There was a lot of fear around learning more about the trauma. So the other person, or, you know, you can think about this broadly to other people, and folks who have PTSD, people in their lives maybe not having great responses when they share. And so we got an experience of living that out in the room, of preparing that there might be disclosure, and then having that be the case in the MDMA session, where the partner with PTSD had, you know, naturalistically gone into a memory and was having strong emotions come up with that and was sharing. And then the partner being able to witness and being able to be in a place of being present and compassionate and understanding that it wasn't harming them to hear, and was able to offer that presence and care to their partner. And that was really beautiful to witness, and was a real turning point in their relationship, of feeling like they could be honest and present with each other.
I can just chime in and say that in my observation is, and I think this is really interesting, I think this question of what are we trying to target? Is it, you know, PTSD, obviously, what I have found to be the most profound is the relational changes that occur. And I think it's both the relationship with themselves, the relationship with their partners, with their children, and in many ways leaning into connecting. And I think that's something that maybe some of our treatments historically haven't always moved the needle on. And I've had, you know, folks become, you go back to, you know, scuba diving, become Tai Chi teachers, you know, lean into being a parent. You know, none of these are things that we're targeting in treatment. The PTSD is going down, but what has blown me away is how much fuller their lives are getting, in ways that I think are very much a product of some of what's happening in the room above and beyond, or maybe alongside what's happening with reducing the PTSD. And so I feel like, and that stuff that's the good stuff in my mind. That's the stuff that makes your life full. And I think sometimes in the field, we do focus a lot on symptom reduction, as we should in medical settings if we're treating a disorder. And we want people to feel full and connected in their lives. And this feels to me, you know, qualitatively different than what maybe some of our other treatments have had.
I can talk a little bit about a case, and also hopefully it illustrates how combined a therapy it is, especially for us on dosing day, because we are we'll dose in the morning and then invite people to go inward for about 2 hours. So kind of the MAPS model, putting on an eye mask and the headphones. And then after about 2 hours, we'll invite them, if they're ready, for the first imaginal exposure session. And then we process that. And then we invite them to go inward again, and then have another imaginal exposure session and processing. And with one of our patients during the inward, she asked, can I talk to you? So of course, you know, we're here. And she was like many of our PTSD patients, she had been multiply traumatized. And a lot of those other traumas were coming out during this inward period, but she was telling us about them. And so that also kind of was grist for the mill for in the processing, even of the what we call the index trauma that we worked on in imaginal exposure, because they often tied together. There were, you know, she had a long history of victimization and guilt, and so we were able to bring that all together in the processing. And then also with this particular patient, it sounds corny to say beautiful, because it wouldn't have sounded like that outside the door, because she was screaming. But she was screaming and like getting rid of like the toxins of this traumatic history. And she could tell us what she was getting out at different points. She would say, you know, that's my father, that was my first husband. I mean, and she was just like, I think of weird metaphors, and I don't know if y'all remember the Green Mile, and that when the black stuff, like the ash, is coming out of his mouth, the poisons that he's taken from other people, it felt like that. It felt like she was, you know, getting rid of these poisons. And she came in saying, and this was around the time of the Olympics last year. And so she said she had a gold medal in avoidance. And then by the end, she had a gold medal in approaching. I mean, we really, switched it around from that you don't learn from avoidance, but you do learn from approaching. And she really got that.
I just want to add one thing is that I just listening to you, Barbara, and I've worked with you, of course, and Anne, I've worked with you. And I just want to comment that there's a lot of focus on the benefits for the patients, of course, that I think the providers also find this invigorating, a powerful tool in your toolbox. And I think that that is something that we don't talk about enough is our folks that are on the front lines doing really difficult work. And there's benefits also to those folks broadly if we can have more tools that we feel like leave us feeling the way I think many of us have felt, where we're moved, we're emotional, we feel like we're seeing growth in front of us. That's not insignificant in this space either.
Well, thank you all so much for a really fascinating and engaging discussion. It's really exciting to hear from the leading researchers and clinicians at the cutting edge of this work. And I think it might be helpful as we wrap up in the last minute or two here to let folks know how they can follow your work, how they might be able to refer patients to your studies, and then any other parting thoughts for the attendees.
And I'll just say quickly, thank you all so much. It's so good to know that these important questions are in such good hands and thoughtful hands. And also, we have so many interesting and thought-provoking comments in the chat. I wish we could get to more of them. So thank you all for being so engaged today.
Treat to get to be with you all. Thank you. And we are recruiting right now for our couples study. And so it's actually dyads, one who has PTSD and one who doesn't. And it actually can be any two people in close relationship, doesn't have to be romantic. So if you go to remedyinstitute.ca, then that's where you can get information. The caveat being you need to be in the Toronto area. So if there's anyone you know in the Toronto area who would qualify, you're welcome to contact us.
And I put the email for our study. Currently, we're offering MDMA NPE in an open clinical trial. We have been approved for funding for 2 DoD trials, one in active duty service members and one for civilians and veterans within the 2-week program, but the same. And those will probably start seeing patients in those trials after the first of the year, around the first of the year. So the same email should get to us for that too.
I'll just say clinical trials across the board for folks is the best way for people to find out what's happening and how to get involved. And that's always going to be the case in the US at least. So
Thank you
Fantastic.
for involving me. This was fun.
thank you so
much
much.
for doing this. And thanks everyone for participating today.
Yeah,
Be
thanks
well.
everybody so much. Take care.